Go ahead and get started. So welcome everybody again. You are here at the launch of the Year 10 NELA dataset webinar. Today speaking, we have Lindsay Pierce, who's a consultant general and colorectal surgeon at Salford Royal and also our NELA surgical and research lead. Dr. David Saunders, who's a consultant anesthetist at the Royal Victoria Infirmary and also our NELA anesthetic lead. And we have Inang Lo, who's our NELA anesthetic fellow working at St. George's. Before we get started, just a few reminders. If you have any questions or comments, you can submit them through the Q&A tab within the Zoom platform. If you're having any audio or visual problems, you can just exit and restart Zoom, and hopefully that will solve things for you. We will have a recording of the webinar available in due course. We'll send it out to all attendees, and we'll also post to our NELA website. And there will be a post-webinar survey for you all to complete afterwards. So please take a few minutes to do that. So without further ado, I am going to let Lindsay take it from here.
Thanks, Christine. I'll just share my screen for you. Okay, so thanks for the introduction, Christine. Yes, I'm the surgical and research lead for NELA at the moment, and together with Dave Saunders and other members of the project team, we've written the Year 8 report, which was published in February. So I'm just going to quickly flick through the key findings from that report and sort of explain where we're heading from here on in. So published in February 2023, just over 22,000 patients were included in the Year 8 report. You will have noticed if you read the report that the case ascertainment data will follow when HES data is available. So if we kick off first of all with radiology, radiology are clearly still under significant workforce pressures at this time. In the Year 8 data, we saw that 63.4% of all reports were done by in-house consultant radiologists and 26.3% were outsourced. That's quite a significant increase on Year 7, where there was only 19.1% that were being outsourced. So there's a clear indication that outsourcing is certainly here to stay and probably on the increase. Assessment of mortality remains good, and we've been quite consistent over Year 7 and Year 8. However, timeliness to theatre is where we've really identified that there is significant pressure. In previous reports, we've looked at time to theatre from time of decision to operate, and we've always felt that that possibly sheds light onto the timeliness of the pathway in a more favourable way than potentially patients are actually experiencing. So we've decided to look at time of arrival in hospital to time of arrival in theatre for our emergency laparotomy patients. And as a surgeon, I know that not every patient comes through the door and needs an emergency laparotomy immediately. And there are groups of patients for whom a period of watchful waiting and conservative management is entirely reasonable, such as patients with adhesional small bowel obstruction or diverticulitis. So in order to try and remove some of those patients from the patients that we were looking at, we created some surrogate groups to try and group together patients who we felt were likely to need urgent surgery. So pre-op systolic blood pressure that's low, sepsis suspected at time of arrival in hospital, predicted gross peritoneal soiling, and sepsis suspected at time of admission to operate. And what we saw in those groups is that consistently across all the groups, patients were really waiting an excessively long time from arrival in hospital to arrival in theatre. And we felt that patients were experiencing unacceptable delays from when they arrive in hospital to when they arrive in theatre. And when we looked at those groups, but with the sort of frame of time from decision to operate to time of arrival in theatre, we could see that time of arrival in theatre with those markers was considerably shorter. And so there is an extraordinarily long amount of time where patients are waiting for that decision to operate to happen. Anaesthetic input for preoperatively particularly has tailed off year 7 and year 8, and we think that that probably is related to COVID and a hangover from the COVID period. High risk patients though do have anaesthetists and surgeons in theatre, and that's pretty consistent, but there has been a drop off in admissions to critical care post-operatively, and again we think that's possibly a hangover of COVID and capacity issues. Elderly care input remains low, but it has improved a little bit in year 8, but that's also an area of concern. And then there are a number of other outputs that are not RAG rated, and in a similar vein to the timeliness of arrival in theatre, timeliness of antibiotic administration has been something that we've been somewhat concerned about. And in the data, we found that only 23% of patients with suspected sepsis at admission receive antibiotics within an hour. And 25% of those patients who have suspected sepsis at admission wait in excess of 7 hours for their first antibiotic dose. Unplanned admission to critical care and in-hospital mortality rates have both plateaued over year 7 and year 8. So our real drivers at the moment are to try and improve our time to theatre and the management of infection. And what we've identified from the national data is that patients have this sort of circuitous and prolonged route through the hospital from time of arrival in hospital to decision to operate, but that once decision to operate is made, there seems to be a relatively smooth and timely pathway to theatre. And this is just some AHSN data from one of the AHSNs that I've presented to in the last year. The hospitals are represented by each horizontal bar. And what you can see from this is that the pink area is decision to operate to time of arrival in theatre, and the blue area is arrival in hospital to arrival in theatre. So in terms of proportion of the pathway, there's significantly more time spent from arrival in hospital to decision to operate. And whilst decision to operate to arrival in theatre remains reasonably consistent across organisations, even within an AHSN, the time from arrival to decision to operate varies much more greatly between the hospitals. So it's that variability that we really need to target now to try and improve outcomes for our patients. So thank you for listening to me. I'm now going to hand over to my colleague, Dr. David Saunders, who is an anaesthetist and the NELA anaesthetic lead, who's going to talk you through some of the changes that we're looking to make for the year 10 dataset and the evidence behind those.
Okay, thank you very much, Lindsay. I'll just set away sharing my screen. Okay, I think that's sharing. Yeah, thank you, Lindsay, much appreciated. Good afternoon, everybody. So I've got two topics really to talk about just now, and that because of reasons of time, these are quite constrained slides. Firstly, I'm going to discuss some quite extensive work that the project team of NELA have undertaken through this winter, 4 or 5 months worth of work, reviewing and updating the clinical standards against which NELA will audit from next month. So this standards review work has, I think this has gone on since the inception of the project. It's always been an iterative and evolutionary process, but it's quite timely with a new contract for NELA to review this in a little bit more detail. And that review of the standards, that informs the data set and the questions that will be posed in the revisions to the web platform that are also coming from next month. So it's a good opportunity to introduce you to some of those concepts. Secondly, I'll outline how we think best practice tariff is going to work from next month, because there's been a change in focus. More about that in a moment. Okay, please do ask any questions as we go along. So we've reviewed a whole list of publications made by other bodies. I'm not proposing to talk through all of these, but there's one really important one that I do want to draw to your attention, published by the Royal College of Surgeons 2018, The High-Risk General Surgical Patient. I would strongly recommend, if there's one thing to take from my slides, please do read that guidance. And that single publication has informed lots of the standards that NELA has adopted to audit. Really importantly, this is a change in mindset, I think, that's going to be required, certainly for me as an anaesthetist. We need to think about the categorization of urgency of the patient's care, not just from the point of decision to operate, which traditionally has been when the clock has started for purposes of rag rating the performance of hospitals within NELA, but instead it's from the time that the patient presents to hospital. So right from the get-go, patients need to be categorized as per the RTS into one of three categories: those requiring immediate management, non-immediate management, and a third category of non-operative management. And importantly, these terms apply to both the diagnostic aspects of the patient's pathway as well as the laparotomy and management pathways. And there's an element of chicken and egg here, because you can't know whether the patient's pathology falls into requiring immediate management until you know what the diagnosis is. So it's going to be important that the default position for an adult patient presenting to hospital with an acute abdomen is that they fall into the immediate category of diagnosis and management until proven that in fact they're in the non-immediate or non-operative pathways. So examples of the kind of pathology that would be classified as requiring immediate management would be a perforation or infarction to the bowel, uncontrolled hemorrhage, generalized purulent or feculent peritonitis, strangulated or ischemic bowel, tender bowel obstruction at risk of perforation, or systemic sepsis. Those patients that can be managed in a less immediate or non-immediate manner would include those with a non-tender bowel obstruction, or perhaps those with suspected intra-abdominal infection but without systemic sepsis, for example, diverticulitis. The non-operative group, Ineng is going to discuss in a bit more detail shortly, so I won't dwell on that group just now. So from April, that's year 10 of the NELA audit programme. There's a whole list of different topics that we will report against at the end of year 10, and we will rag rate the performance of hospitals against a number of different metrics. Some of that as we go along, some of that will be in the annual report. But I'm just going to pick out 4 of these just now as examples of the evolution to the standards in the data set. So radiology, this boils down to whether or not a CT scan was done, the timeliness of the request for that CT and the reporting of it, the grade of the reporter, and a new topic there around direct discussions between the reporting radiologist and the requesting team, whether that's the emergency medicine team or surgery. So NELA will rag rate the proportion of patients who receive or should have received immediate surgery who had a CT scan that was reported by a senior radiologist within 1 hour of the scan being undertaken. And secondly, NELA will rag rate and report the proportion of high-risk emergency laparotomy patients who undergo preoperative CT scanning where there is direct communication between the reporting radiologist and the surgeon, either by telephone or in person. So above and beyond a written CT report. Okay, example 2, risk assessment, preoperative decision making boils down to effectively, was a mortality risk assessment done, as we've reported for a number of years. The definitions of what constitutes a high-risk patient, a subtle evolution there. So as previously, a NELA calculated mortality risk score of 5% or greater makes them high risk. Clinical judgment of being high risk labels the patient as high risk. But importantly, if the patient is significantly frail, defined by a clinical frailty scale score of 5 or greater, that will also categorize the patient as being at high risk. Finally, the absence of any form of formal risk assessment categorizes the patient as being at high risk. So the kind of RAG-rated metrics that NELA will report include the proportion of patients where a standardized mortality risk scoring tool has been used. And secondly, a sort of composite measure where the proportion of patients in whom a risk assessment was documented both preoperatively and postoperatively. Now, the risk scoring algorithm within the NELA platform is changing, hopefully changing to make it easier. So we've called this a parsimonious risk score. At the moment, there are about 22 variables that go into giving a NELA mortality risk assessment. That is being reduced to just 13 that are on that slide in front of you. Importantly, the last variable that is now informing the risk assessment is the predicted surgical pathology to some extent. So currently sitting in tab 5 of the platform is a big long list of indications for surgery. And that's always sat in a slightly anomalous place in the registry because it's part of the tab 5, which is data collected in theatre once you know what you're dealing with, but it asks a question in hindsight or at the time of booking the case, what was the indication for surgery? So that's being moved forward now as part of the risk assessment. The same list of options is available. And then behind the scenes, the algorithm categorizes that specific indication into one of just 5 STEM categories, if you like: ischemia, sepsis, bleeding, obstruction, or other. And there's a hierarchical nature to these where it looks for one and that might score higher than the next, might score higher than the next. It's difficult to describe in a short space of time, but that will become apparent when you start to use the web tool. We can talk about that in more detail if you'd like to from some Q&A. Okay, third example of standards review and subtle changes to the data set around timeliness of access to theatre. So we've reported on this for a while, but instead of reporting against a self-stated urgency of getting to theatre, we will look retrospectively because we will know the findings in theatre and we will report the proportion of patients who received or should have received immediate surgery within 6 hours of arrival in hospital. And secondly, we will report on the proportion of patients where it is recorded that access to theatre was delayed beyond the original intended urgency. Final example around the frail and elderly patients, whether or not a frailty assessment was done and whether or not post-operatively the patient was seen by a member of the hospital's perioperative medicine frailty team. So there's a subtle change in wording to date that has always said elderly care. That's been broadened. That definition has not come from NELA, that's come from the Centre for Perioperative Care, CPOC, at the Royal College of Anaesthetists. So NELA will report the proportion of patients aged 65 or older where a formal assessment of frailty was undertaken. And secondly, NELA will report on the proportion of elderly or frail patients who received post-op assessment and management by a member of the hospital's perioperative frailty team who has expertise in comprehensive geriatric assessment. So that's all I'm going to talk about just now around the standards and dataset changes. Just to emphasize, please do look at this publication from the Royal College of Surgeons. It's really important. Okay, moving on. Best practice tariff emergency laparotomy from next month, 23 to 25. So for those in Wales, this does not apply. Emergency laparotomy best practice tariff applies to those hospitals in England. The tariff is set by NHS England. The performance of trusts, not individual hospitals, will be measured by NELA, and payments will be made by commissioners directly to those trusts. There are 2 parts to the best practice tariff. Both of these standards need to be met to meet the enhanced tariff. So firstly, risk assessment, the proportion of all patients who receive a documented assessment of mortality risk as part of the decision to operate. And the target there is 85% of all NELA patients need to have had that formal assessment of mortality risk preoperatively. Secondly, perioperative frailty team input, the proportion of patients aged 80 or older or 65 and frail who receive input by perioperative teams experienced in the management of older patients. The target there has been set quite low at just 40% for the forthcoming year, but that is likely to increase quite rapidly over subsequent years. So the way this works is that there's a base price and an enhanced best practice tariff price. The base price is set at 90% of the best practice tariff price. There's a precondition for hospitals that want to claim the best practice tariff. So there must be in place agreed multidisciplinary pathways of care, agreed between all key stakeholders: emergency medicine, surgery, anaesthesia, critical care, elderly care, radiology. And those pathways in place must cover as a minimum both diagnostic and laparotomy phases of the patient's pathway. The tariff differential is worth, on average, £900 per case, and I'll show you that in a moment. But the number of patients assessed for whether or not best practice tariff was met, the number of patients where payments are made is not identical to the NELA registry. So the assessment of standards is against the data recorded in NELA, but payments are made for all cases meeting a basket of HRG codes, operative codes, which I'll show you in a moment. But the whole thing does require engagement with NELA. So good case ascertainment within the platform is a precondition of payment of best practice tariff. I'll show you our understanding of how it works, but risk assessment, let's just emphasize this. There needs to be a formal mortality risk assessment, i.e. that is the NELA parsimonious risk score as just described. That needs to be documented in the notes to meet this standard. An assessment of frailty can inform clinical judgments about whether or not the patient is high risk, but a frailty assessment alone is not adequate to say a formal assessment of mortality risk has been done. Number two, perioperative teams experiencing the management of older patients. So this wording has been taken from guidance published by CPOC, and it states that the perioperative team should be multidisciplinary and have expertise in comprehensive geriatric assessment to deliver what's on the screen in front of you, which, as I interpret that, the majority of practitioners that can deliver that standard of care are members of the elderly care community. But I think the way it's been worded, it opens up the option that a perioperative physician with specific training and expertise in comprehensive geriatric assessment could also now meet this standard, rather than it being specifically an elderly care doctor. So BPT, how does it work? Or which cases will the trust be paid for? If there's an example trust, blue circle, with 100 NELA cases, they've got good processes for risk assessment. 90% of their patients receive a risk assessment. Half of their patients, which is about average, are elderly and or frail. And of those elderly and or frail patients, 21 of those receive perioperative medicine frailty team input post-operatively. All the standards are met in this hospital. The payments, however, will be made on a subtly different patient group that largely overlaps the NELA registered cases, but defined by HRG codes. So an example here would be a patient who has a hemicolectomy because of appendix pathology is not a NELA eligible case, but the HRG code for that operation is eligible. So it's likely that the payments actually will exceed in number. There'll be a greater number of patients against which payments will be made greater than the NELA registered cases. So in this example, the BPT uplift on average £900 times 105, £94,500. Well, it depends whether you can see that as extra payments, or you can say that is the risk of losing that nearly £100,000 worth of income if the standards are not met. If case ascertainment is poor, so in this example, there are just 60 NELA cases registered. In fact, there were 100 patients that should have been in the registry. The standards of care in that hospital are good, but the commissioners may well decide not to make payment on all 105 patients because case ascertainment is poor in NELA. If risk assessment is poorly done, so this hospital has a similar number of NELA cases, similar proportion of elderly, frail patients, and good processes of care for postoperative frailty team input, but risk assessment is badly done, the BPT standards would not be made and the money would not be forthcoming. Likewise, in this hospital, they're good at doing risk assessment. They've got 50% of their cases are elderly or frail, but they have inadequate resources for frailty team input. Just 10 patients out of 50 were seen by the frailty team postoperatively. BPT will not be paid. So how much is it worth? That's the HRG basket of cases with the codes down the left-hand side and a description of those operations in the middle. There's the best practice tariff, the non-best practice tariff, and the potential uplift in or downlift, depending upon which way you want to look at it, in tariff. So on average, it's about £900 per case on all of those patients operated on in your hospital that meet those codes. Importantly, so the same operation in a more comorbid patient, not only is the absolute tariff increased, but the differential increases. So that's an important role for the coders within hospitals, that comorbidities are coded accurately and comprehensively. So that's all I'm going to present. I've talked to you there about some of the changes to standards that NELA will audit against and how they have shaped forthcoming dataset changes. In particular, I've introduced you to this parsimonious risk score and also talked about this change in wording towards the perioperative medicine frailty team rather than elderly care. And I've reviewed there how we envisage best practice tariff working in England. Thank you very much. I'll hand over to Neng to talk us through the exciting NOLAP project.
Thanks, Dave. Just before Neng starts, I just wanted to remind everyone to use the Q&A function. We've had a few questions that have come in so far, but we've had loads and loads of information and lots of new information. So if there's anything that you or your colleagues want to ask any further questions about, stick it in the Q&A, and then when Neng's finished talking, we'll rattle through as much information as we possibly can. Away you go, Neng.
Oh, thank you. I'll start sharing my slides. Right. Thank you, Dave. Thank you, Lindsay. And thank you for the opportunity to speak at this webinar today. A very good afternoon, everyone. So I'm going to try my best to give you an outline of this new project, the NOLAP, that NELA is currently setting up. And we hope to roll this out in April 2024, which is the next financial year. And starting off, I'm going to give you an introduction to the project, moving on to what we have done so far, what we're currently working on, and our next steps. So since 2012 till today, the data that NELA has collected for patients undergoing emergency laparotomy has allowed us to identify areas of clinical priority, and this has led to improvement around perioperative care for patients undergoing emergency laparotomy. However, on the flip side, we have another group of patients. It's the one highlighted in the red box. And these are patients who require emergency laparotomy, but did not proceed to have one. So this no laparotomy or no lap group of patients remain unexplored, and we have very little knowledge about them. We're not clear how many patients constitute this group, their demographics, their underlying pathophysiology, and what their short and long-term outcomes are. And with so many unknowns about this group of patients, trying to define what treatment options are best for them is quite limited. And it also directly restricts shared decision-making in this critically important group of patients. And some of the examples about these areas that we would like to know more about this group of patients are reasons why they don't have laparotomy. Are they being referred to end-of-life care? And if not, why? Similarities and differences compared to their counterparts who have laparotomy. Now, you probably ask, what is the prevalence of this no-lap group of patients? So from the literature search that we've done so far on various databases, we managed to identify 2 prospective cohort studies looking into this no-lap group of patients that have been published. So locally in the UK, McKelvin and her team has conducted a single-centered prospective cohort study. They tried to characterize this no-lap group of patients, looking at their outcomes compared to their counterparts who received emergency laparotomy. They managed to recruit just over 300 patients, and about a third of these patients did not undergo laparotomy. So their prevalence of no-lap in their study is about 32%. There is also a similar study that was done in Denmark. They managed to enroll 250 patients into their cohort study, and they found just under 10% of patients fulfilling the definition of no-lap. And what is interesting from both studies is that the most prevalent diagnoses among this group of patients are similar. So the top 3 diagnoses are intestinal obstruction, perforation, and intestinal ischemia. As you can probably imagine, this is an extremely challenging group to identify because there is no defined event in their care like the emergency laparotomy patients. And what we need is a more robust definition of this group of no-lap patients. And currently what we're working at with the preliminary definition is patients who present with an intra-abdominal pathology whose condition is only amenable to laparotomy, but not being offered a laparotomy. And we go by all the studies that are available, and this is what we learned from them. And so in order to guide our future projects, we've decided to divide this project into 2 main stages. So for the first stage, we'll be looking at the most common diagnosis within this no-lap group of patients, as what we've learned from the 2 cohort studies, which are intestinal ischemia and perforation. Further down the line, we'll then be expanding into other abdominal pathologies, which could be broader and more challenging to define. And similar to the emergency laparotomy group, there will be 3 main components to our project, which is case ascertainment, developing the question pro forma, and then moving on to data collection and analysis. And so currently we are working on the first 2 components, which is to develop the case ascertainment pathway and also the question pro forma, which we will be setting up a nominal group technique to contribute to this. I'll come to it in my slides later. So starting off with case ascertainment, we have identified all the potential ICD-10 codes that will fulfill phase 1 of this project, which is intestinal ischemia and perforation. We'll be getting records from HES data in England and the patient episode database from Wales to look at diagnosis codes that we have listed, and combining with OPCS records, we'll try and identify patients that meet the criteria for no-lap. This is quite a challenging area because, as I've mentioned before, patients do not have a defined period like the emergency laparotomy patients. So there is a possibility that the case ascertainment might be slightly underestimate the number of patients. Moving on to nominal group technique, this is the next component that we are working on, which is to develop the question pro forma and setting key metrics for this group of patients. And to try and achieve this, we'll be running a nominal group technique virtually. So what is a nominal group technique? And very briefly, it is a form of consensus methodology, which is highly structured. I'll come to this in my next slide. The aim of this is to achieve convergence in opinions and to vote and rank ideas, which at the end of the meeting, we hope to achieve consensus among panel. There will be a meeting chair and a panel of experts. And for this meeting of ours, we aim to have a multidisciplinary panel of experts, and they have all done some work in this area of NOLAP, or they are experts in emergency laparotomy research and surgical futility. So coming back to our project, we hope that we can establish a more robust definition of NOLAP through this meeting, and also to identify any crucial care processes and care domains for patients through this meeting, which will help to form our question pro forma. And I mentioned earlier that this is a very highly structured meeting, so there will be 5 stages to this meeting to ensure that ideas are generated, and everyone on this panel will have equal opportunity to voice their opinions, and there will be a chair to ensure the smooth running of this meeting. These are some examples of the care domains that we will be discussing during the meeting. This is not an exhaustive list, and it's open to more discussion during the meeting. I've broadly divided it into 3 sort of presentation types. So at the time of presentation, in hospital care, and at the time of discharge. So most important next step is to develop the question pro forma to guide our data collection, which we hope to roll out in 2024. And so we'll be updating you from time to time, so watch out for this space. Thank you.
Excellent, Ian, thank you for that presentation. So after only having a few questions, they've come in thick and fast now during Ian's presentation. So we'll start to just field some of those questions. Ian, I don't think there's any that have come in for you just yet.
Mm-hmm. Yeah.
Dave, you answered one about frailty not being included. You just want to share that with everyone. So why is frailty score not included in the new NELA risk score?
Yes, thanks, Lindsay. So I think it's just technical. The way the parsimonious risk score has been developed is looking backwards at NELA data that was collected in the past and then validated on a even greater patient cohort. And at that time, frailty assessment or the frailty score was not recorded. So perhaps in the future, the frailty score can be embedded within the NELA risk algorithm. But for now, it won't be. Yeah. I suspect the parsimonious risk score will continue to evolve.
Yeah.
With greater granular data.
Perfect. So along a similar sort of line then, we've had lots of conversation, haven't we, within the NELA project team about this new terminology with CPOC and frailty and what constitutes a perioperative team. ACPs, clinical nurse specialists, allied healthcare professionals, what's our feeling around non-doctor grades providing frailty assessment?
Right. Yeah, we have discussed this. And it's important for the delegates today. NELA haven't defined this. We've been asked to provide this data back to NHS England. So my interpretation is that, so at one extreme, you could say that an elderly or frail patient who's been through critical care has been seen by a consultant intensivist who has expertise in perioperative medicine. Does that meet the criteria? That does not. That is certainly not the spirit of what the whole thing is about. And at the other end of the spectrum, a patient who is seen on the step down surgical ward during the rehab phase of their illness by a consultant geriatrician, that absolutely does meet the criteria. But between those two extremes, there are graded responses, and hospitals will work hard to improve their perioperative medicine input, I'm sure. So my own feeling is that a nurse specialist or a elderly care registrar working under direct or indirect supervision of a consultant geriatrician, and all those people I've just described will have improving expertise in comprehensive geriatric assessment. They would meet the criteria. Where I think it's slightly grayer is hospitals that have, for example, perioperative ward rounds led by a consultant anaesthetist who does see perhaps elective patients currently, but then there's a request, could you take on seeing these emergency laparotomy patients as well? Perhaps that service is already in place. Now that team almost certainly will not have specific expertise in comprehensive geriatric assessment, but the bit I find interesting is asking the question, how does that specifically differ from the specialist nurse who is also working under supervision of a consultant geriatrician? That assumes that the anaesthetist has access to that geriatrician. So we have, for the delegates listening, we have asked NHS England for some clarity on this. And once we get that, we will distribute that through our networks. Thank you, Lindsay. It was a bit long-winded, but.
No, it was perfect. I think it's a lot less long-winded than the circuitous conversations that we've had with the project team and going backwards and forwards about it. So I think at least we've got a standpoint where we're at now. There was one other question that's come into the Q&A in along a similar line. Do elderly care physicians count as perioperative team if they receive referrals from surgical patients, even if not directly within the surgical directorate or team? I presume that means that they are essentially an in-reach service rather than based within the surgical directorate team. And yes, elderly care physicians absolutely would count as a perioperative team, because they would be trained in comprehensive geriatric assessment, and it doesn't matter whether they're in-reach or based within the surgical directorate. Okay.
Yeah, agreed. And to add to that, Lindsay, very important then in that sort of service that the data is accurate, because that hospital must not sell itself short. That would be a good service if an elderly care consultant can see the patient, but very important that that's then recorded accurately in the web platform, because that's how judgments will be made.
Yeah, agreed. Okay, so moving on to risk score. There's a couple of questions around risk. Does putting the NELA risk score into a digital booking form for the case to be accepted to theatre equate to meeting the risk assessment standard?
So I would say yes, if a NELA risk score has been done on a standalone risk calculator.
Agreed.
Doesn't matter where that calculation has been done, it meets the standard.
Absolutely. Yeah, as long as it's been done, it doesn't matter where you put it, it's just as long as it's been done and it's been done properly, then yes, that would be acceptable. Okay, so there's a question here, and again, we've had lots of conversation between ourselves around this. So is the NC pod classification of surgical priority not being used anymore? Most NELA procedures would be 2A, i.e. urgent, as opposed to 1 immediate, and have different time guides. Do you want to start talking about that, and then I can chip in from a surgical perspective as well?
Yeah, so direct answer is we will still collect the NCPOD classification. If nothing else, because it forms part of the parsimonious risk score, because that data was available during the development of that algorithm. So we need to retain that. And it does remain relevant. The way the hospital functions in terms of getting a patient to theatre from the time a decision to operate is made, that remains important. And it's not universally well done. But it is important to sort of shift your mindset that up till now, that has been the standard that NELA has reported, hasn't it, around timeliness of theatre access, starting the clock at the time of decision to operate. But we need to think more broadly about the entirety of the pathway from when the patient presented to hospital. So it is still being used, but it's only part of the story.
Yeah, absolutely. So we're sort of suggesting that we're moving away from NCPOD classification, but we need to keep it because it's part of our risk score. So it's integral to our risk scores at the moment. But we would like to move more towards what we see in the high risk surgical patient document. Okay. moving on. They're all different topics.
There's a question here, Lindsay, that I could answer about out-of-hours CT reporting using outsourced service. So at the end of this of year 10, so that's the audit year we're about to start, we are dropping the plan to RAG rate the proportion of CT scans that are reported by in-house versus outsourced radiologists. I think we've agreed to do that. Instead, we feel that the important thing from the standards that we've reviewed, it's around communication. So if the outsourced CT reporting service has good communications with a phone call to the referring surgeon or emergency medicine team, then that will meet the standards. We're not, I don't think I could comment whether or not outsourced is inferior or superior. I'm not a radiologist, that's really for them. But to some extent, that ship has sailed, because we know, we've seen some of the provisional year 9 data that we're currently in, and about 60% of scans are now, the reporting is now outsourced. So whilst the perfection might be an in-house GI radiologist reporting all CT scans, it's just not possible with the current resources available to departments of radiology. So the focus will move more to the quality of that communication and the ability for, when there's an apparently anomalous CT scan report that just doesn't fit with what's in front of the surgeon, that's where the phone call is really important. That's my understanding.
Yep, agreed. Perfect. Okay, I've got 2 questions for Christine, who is hovering in the background. Now he's going to panic because I'm going to ask her a question. So Christine, there's 2 questions relating to, one, NELA app. Is the NELA app going to be updated with a new parsimonious risk score?
I don't think there are plans to do it immediately. So currently, with the updates to the risk calculator, we're focusing our efforts on the computation that happens within the data collection portal. And there's also a standalone risk calculator available in that data collection portal that will also be updated. We'll have to take the app discussion back to project team, but there aren't plans to have that updated immediately.
Okay, thank you. And second question, I'm not sure whether you may have already answered it. Are there plans to have face-to-face annual NELA days? I saw somewhere.
I saw this question as well. If those happened previously, they were before my time as a member of the NELA project team, so I'm not aware of those. Short answer is no, we don't have anything currently planned, but it doesn't mean that we couldn't look to do something like that. For example, after the publication of an annual report, again, something that we can discuss within the project team.
Yeah, agreed. I mean, I think we need to, COVID's happened, we've all been online. It'd be nice to be back face to face at some point. But yeah, if there's things that you as clinicians who are collecting all this data want from us as a project team, and if that's something that you feel would be beneficial to you and your organisation, then please do let us know, and we can look at trying to provide what you need from us. Okay, right, we're going to move on to a bit of NOLAP in a minute. So there's a question, well, comment really, and this person has clearly on the same page as me and given me sleepless nights about trying to sort out these NOLAP patients. So just to be absolutely clear, NELA is a national account audit which is commissioned by HQIP. And we had to apply for a retender to renew our contract to be able to continue to collect this data. And as part of that contract renewal, we have been requested by HQIP to start to collect data and information on patients in the NOLAP group. So this is not something that's come from NELA project team, although there are people on the NELA project team who are very interested in outcomes for NOLAP patients. This has actually come from top down. So we are being asked to do this by HQIP, and it's our role to try and work out how we best do that. So this comment says it's going to be really difficult to get a nice group. You'd not want to include patients with mild diverticulitis, but you do want to include patients with perforated diverticular disease who are unfit for surgery, antibiotics and interventional radiology. Spectrum's wide, standardization will be really difficult. Yes, all of the above. And it's a massive ask for NELA leads to try and capture these patients who already have many hundreds of NELA cases to be submitted each year. So Eneng, how are you so what we've tasked Eneng to do as a project team is to basically explore this NOLAP issue and try and work out how we are going to capture those patients in the best way possible and what experts in the field feel we should be doing in order to try and report accurately on the right population. So Eneng, our NELA leads and all the clinicians that collect NELA cases are doing an amazing job. How are we going to support them?
Right, so I think there are two parts to this question. So I'll go to the first part first. I think we do appreciate, and whilst I'm working on this project, that I agree this is a very wide spectrum and it is a very difficult group to define, as I mentioned. But we need to be clear, I think, because when I first started off as well, I was a bit confused as well with this concept. But we do have patients who are being actively managed conservatively, and those are not the patients that we would want to include in NOLAP. So for the NOLAP group, we have to be really clear that we only want to recruit patients who have a condition that they would have had a laparotomy, but they weren't having one for whatever reason. So if they're being the decision is to make that they're being observed or actively managed conservatively, but with the view of having an emergency laparotomy down the line if they deteriorate, that wouldn't be a NOLAP group of, that wouldn't be a NOLAP patient. Or patients who are, just to keep things a bit simple, so patients who are having interventional radiology intervention, we won't be recruiting them into the NOLAP group as well. Then moving on to the second part of the question, which is how to collect data for this NOLAP group. We appreciate that it's already a lot of work being done for the emergency laparotomy patients. We had discussions about who should be collecting it. And I think most of the NOLAP decision, we would think that they will be made by somebody senior, at least a senior registrar in the general surgery team. So either a surgical consultant or a surgical registrar. So this might go back to the surgical team to actually fill in the database for the NOLAP group. We recognize that this is a lot of work and additional work to the team, but maybe there will be a research team or lead or a research nurse that will be able to help. This is also something that we are still exploring and working out on how to best go about this. I'm not sure if you have anything to add. Yeah.
It's a really tricky thing, and particularly with regard to case ascertainment, because we just don't really know what the denominator is going to be. So there's lots of things to work through, and we will try and make it the least burden possible for our clinicians. But I think it's going to be keeping track of patients who are reviewed by by the registrars or by the consultants, and active decisions for non-operative management due to futility or another, whatever the reason, clearly being documented. Okay, thanks, Eneng. I will go back to the questions if I can. We had one that I just saw pop up. Is post-op frailty assessment acceptable? It's difficult to find an elderly care doctor in an emergency. Frailty assessment is something that every clinician should now be able to do. You don't need an elderly care doctor to undertake a frailty assessment. In fact, most patients have some sort of frailty assessment in the emergency department now. Dave, I'm going to come back to you. Best way to encourage the implementation of an emergency laparotomy pathway and the importance of it in terms of best practice tariff criteria. That could probably be a webinar on its own, I would imagine. But you have got, well, we've got 5 minutes left, so you can answer it in a minute.
The best way to implement it. So yeah, the easy bit. So I've tried to walk this journey myself. The easy bit turned out to be getting the content of the pathways. The hard bit then is implementing that change. That's what is very difficult. If I was starting from scratch, I would borrow someone else's and adapt it to your own. Borrow one of the one, and there are many. There are some hosted on the NELA website, example pathways. There's one in the northeast of England that's been agreed, certainly between all hospitals in the northeast, and I suspect that's gone on elsewhere in the country. That's a really good starting point. That's where I would begin. How you then implement those changes, though, as I say, is much harder.
Yeah, and we did do a webinar on sort of best practice elements some time ago, and that is recorded on the channel. Okay, bit of confusion. Is the BPT for consultant presence in theatre and admission to critical care for high-risk patients, mortality 5% and above, no longer being used from year 10?
So that's a good question. I didn't speak to that. I should have done. Those standards are still expected to be met, but whether or not they're met will not have, there's no best practice tariff for it anymore. Those standards are now expected to be met as part of your standard workflows. The best practice tariff enhancements will now swing around towards the elderly and the frail group, trying to drive improvements there. So there's no desire to drop those as standards. They're still seen as important, but instead there's a new focus with a financial carrot attached.
Yeah. Okay. Yeah, there's a similar sort of question. We've been meeting the tariff criteria for the last 4 years, but my trust is on a block contract without the BPT negotiated into it. How do we try and access the additional money from the BPT to improve patient care?
Yeah, I've heard this sort of thing, and it's above my pay grade to understand how these finances work. When I asked our own directorate business manager about this, and I raised a question about the block tariff thing, and I think that's particularly become common during COVID, where the normal payment by results, all of that was suspended and hospitals went onto these block contracts, and some were in it before COVID. The business manager thinks that written into those contracts is still an expectation that best practice tariff standards are met. So just because a hospital is on a block tariff does not mean they are not eligible to receive extra funding if the standards are met. He also went on to, he thinks that from the forthcoming financial year, in fact, the whole block tariff thing might be being shelved and we're back to payment by results. So I think the answer to that needs to come from within the hospital's own finance department, who can advise. But it would be good to pursue that, because that's what might bring extra resources for our patients.
Okay. Right, we've only got 2 questions that are left in the Q&A now. I think we've answered everything else. We've got 2 minutes to go. What happened to the ELCs? The funding ran out for the South London and it was a real shame. We were starting to get traction and it was disappointing. I'm not sure what happened to funding for ELCs. Do you?
So is this the AHSN work? That funding stream has stopped. It ran for 3 years, I think, and it's just been pulled, and they've moved that finance focus into other projects supported by the AHSNs. I think, again, there's a hope that that sort of collaborative work can continue, but there's no financial support in the background. So there's no admin support or managerial support or any obvious funded time for clinicians to set about collaborating with their colleagues. I'm afraid that's just how it goes.
Okay. Last comment was just about specific qualification for Periop elderly care. Yes, there was some sort of qualification. Some surgeons have done it, but I think that for a perioperative team, it really needs to be somebody who's doing CGA regularly and is an addition rather than a substitute. That probably just about concludes us. We're about to hit 1:30. Thank you for all attending, and we'll see you soon at the next webinar. Do get in touch if there's anything we can help with.
Thank you.
Thank you.